Welcome back. Today marks the start of a series of videos about transfusion medicine. This is a pretty big topic, so I've decided to break it up and do a couple of videos because it's a super important topic for critical care medicine. To understand transfusion medicine, you first need to understand blood typing. So today's video is going to be about the blood typing groups, how to blood type, and how to cross-match. To understand blood typing, we need to understand antigens. Our blood type is determined by the presence of antigens on our red blood cells. An antigen is a molecule that can bind to a cell and trigger an immune response. So to determine a person's blood type, a cat's blood type, a dog's blood type, we need to first look at what antigen sites there are on the red blood cells and determine if there is an antigen present on those red blood cells in that site. So we're determining antigen, which in people we look at A, B, O, and then whether there is an antigen present, so positive or negative. In blood typing dogs, we use the DEA system, and in blood typing cats, we use the AB system. Blood typing dogs is a lot more complicated than blood typing cats, so we're going to talk about canine blood typing first. DEA stands for dog erythrocyte antigen, and it refers to the antigens that are found on canine red blood cells. There are 8 DEA antigens described, although only 6 of them are available for routine blood typing. The antigens that are available for routine blood typing are DEA 1.1, 1.2, 3, 4, 5, and 7. There are suspected to be upwards of 18 different types of dog blood type antigens, and a couple other ones that aren't available for routine blood testing are DEA 8, the DAL, DAL, which is a common blood type found in Dalmatians, and Kai, which is Korean for dog. Because of the massive number of dog erythrocyte antigens, for the purpose of this video, we're gonna focus on the ones that are available for routine testing. First, I wanna talk about DEA 1.1 and 1.2. These are actually alleles of each other, meaning they are mutations of each other at the same site on the chromosome. A dog can be negative for both DEA 1.1 and 1.2, but they can only be positive for one of them since they are mutations at the same site on the chromosome. DEA 1.3 has also been described as another mutation at this site, but it's not available for routine testing. The interesting thing about dogs is that they lack inherent alloantibodies against DEA 1.1. And what that means is an alloantibody is an antibody that is made against an antigen on a red blood cell. And this will trigger an immune response, and depending on the severity or the number of alloantibodies present, can trigger a fatal, massive hemolytic transfusion reaction. So, because dogs lack these inherent alloantibodies against DEA 1.1, it has been said that the first transfusion in a dog is free. This is an old school way of thinking, and this is not what you should remember. The first transfusion is never free because alloantibodies begin to be produced just a couple of days after a transfusion is given or after a patient is sensitized to a different type of blood. Because canine red blood cells can live for up to 120 days, in the time period that the transfused red blood cells are still circulating around in our patient's system, they can and will have developed alloantibodies against that transfusion. So yes, the patient is not likely to have a transfusion reaction in hospital while you're administering the transfusion, but they will have a delayed transfusion reaction that will still be detrimental to some degree to our patient. So whenever possible, we should be administering the same blood type as what our patient has. There's not a large amount of in-house blood typing available for dogs. The only testing that we can do is DEA 1.1 in an emergent situation. So if you are administering anything other than universal donor blood to your patient, you should know that your patient will be having a transfusion reaction at some point. Of the remaining recognized blood types, natural alloantibodies exist for DEA 3 and 5, and to a lesser extent 7. Up to 99% of dogs are positive for DEA type 4 antigens. So that means that the universal donor is considered a DEA 1.1, 1.2, 3, 5, and 7 negative, but positive for DEA 4. Okay, moving on to feline blood. Feline blood typing is much more simple. We utilize the AB system. In cats, type A is the dominant blood type. And depending on the reference that you're looking at, somewhere between 94 to 98% of cats have type A blood. Type B is recessive, but because it's recessive, you can see groups of it regionally. I think that here in Salt Lake City, we actually do have a bit of a pocket of type B cats, because it's not uncommon for me to be blood typing a cat in an emergent situation and it be type B. And even less likely, type AB blood is less than 1% of cats. But I have actually had the excitement of blood typing one type AB cat. There are certain types of purebred cats that are more likely to be type B. Rex cats have been reported to be up to 40 to 50% type B, whereas Siamese cats in similar breeds are reported to be 100% type A. Unlike dogs, cats do possess natural alloantibodies against blood types that are not their own. Type B cats specifically possess large, strong quantities of natural alloantibodies against type A blood. Type A cats still do possess alloantibodies against type B blood, but just to a lesser extent than our type B cats do. Because of this, cats have to be blood typed every time for every transfusion. And depending on the resource that you're referencing, there are recommendations to cross-match every single cat every time as well. Type AB cats do not possess alloantibodies against type A or B blood because they have antigens for both. So type AB cats are considered the universal recipients, although due to the precious resource that is feline packed red cells or feline blood in general, we do recommend giving type AB cats type A blood. There have also been some studies that say that maybe type AB cats can have mild transfusion reactions to type B blood. So in general, type AB cats should receive type A blood. So like I said, cats should be blood typed every time for every transfusion, and potentially even cross-matched every time, so that we can prevent life-threatening hemolytic transfusion reactions. The exception here is administering a xenotransfusion, so administering canine blood to a feline in an emergent crisis situation. I'm going to be talking about this more in depth in the next video, where we talk about what blood products are available. I want to take a moment here to talk about something that is not necessarily super pertinent to transfusion medicine, but is pertinent to understanding blood types, antibodies, and how transfusion reactions occur. And the topic I want to talk about real quick is neonatal isoerythrolysis. When a type B queen mates with a type A tom, because type A blood is dominant, the kittens will be either type A or type AB, and they will be being born to a queen with a different blood type than them. While they are in utero, the placenta protects them from any kind of reaction to the queen's blood type because it filters out immunoglobulins. But once the kittens are born and they nurse the colostrum off of their type B mother, which is full of alloantibodies, they will have essentially a transfusion reaction to a massive hemolytic degree. These kittens are typically born normal, but within the first several days become acutely ill. Unfortunately, treatment for this is often unsuccessful once the kittens have already been exposed to these alloantibodies in their mother's milk. If the hemolytic reaction is severe enough that the kittens require a blood transfusion, within the first 3 days of their life, you can administer them 5 to 10 mils of their mother's blood, which sounds weird because, again, these are type A or AB kittens, and we're giving them type B blood. But it takes a few days for kittens to begin to develop their own alloantibodies, so their own anti-type B antibodies. So until that point, the only alloantibodies that they'll have circulating are anti-type A alloantibodies. So they will not have a severe hemolytic transfusion reaction to their mother's blood. After this 3-day mark, when they have started to develop their own alloantibodies, then they should receive type A, preferably cross-matched blood. So you already heard me mention cross-matching. Cross-matching is the act of trying to detect alloantibodies against a certain blood. So for the process of cross-matching, you're taking blood from your donor, blood from your recipient, either using a commercially available kit or using the very long process that is the manual cross-match, mixing them together and seeing if there's a transfusion reaction. There's 2 types of cross-matching. Major cross-matching tests for a transfusion reaction of the recipient's blood against the donor's blood. So to perform a major cross-match, you will need recipient plasma and donor red blood cells. If there is a major transfusion reaction, you should not administer the unit or the donor that you're testing against. Minor cross-matching tests for a reaction in our donor to the recipient blood. So for a minor cross-match, you need donor plasma and recipient red cells to see if there's a reaction in which our donor is not going to be compatible with our recipient's blood. If there is a minor transfusion reaction, if you can, you should give another type of blood that does not have either a major or minor transfusion reaction. But if this is your only option, you need to weigh the pros against the cons of administering this unit, knowing that the recipient blood is going to react to the donor's blood. And it would be a best case scenario if you can avoid administering whole blood in these scenarios and administer washed red cells or packed red cells as opposed to some type of blood product that contains donor plasma. Cross-matching should always be performed on canines that have had blood transfusions more than 3 to 5 days previous to when you're doing it. The reason for that is that canines develop alloantibodies within 3 to 5 days of their transfusion. So this is very clinician dependent, but you may have clinicians that say within the first 3 to 5 days of administering a first transfusion, you do not have to cross-match future transfusions. So in those severe situations where you're giving 2-3 units in a day, oftentimes clinicians will not require you to cross-match every single unit. However, like I said, there are references that say cross-match every unit for every patient every time. And that's gonna just come down to your clinician, your clinic's ability to do these cross-matching, the severity of the situation if you need to get this unit in your patient in less than an hour for it to be life-saving. A quick and dirty way to do a very fast major cross-match is to take 2 drops of recipient plasma and mix it with 1 drop of donor whole anticoagulated blood. You can mix these together and see macroscopically if they agglutinate. If not, you should hopefully be safe to go forward with your transfusion, but this is a quick, dirty way. This is not the way to do a full manual cross-match, so it will not be 100% accurate. But for those situations in which giving that blood is going to be life-saving, doing it as fast as possible, this may be a very fast way to quickly see if your patient is going to have a major hemolytic reaction to the blood that you're about to give them. Okay, I have saved this for the end of the video because it is a little tedious, but I want to go over the steps for how to perform a manual cross-match. Commercial cross-matching kits for major and minor cross-matching are available, and they are faster than doing a manual cross-match, but they are not perfect, meaning if there is any question about the results of these commercially available major minor cross-matching kits, we should still do a manual cross-match to confirm the results. Some people even prefer the manual cross-match and say don't even bother with the commercial typing kits. I'm not here to get on that soapbox. I am just here to tell you guys how to do the long, tedious process of a manual cross-match, which if you work in a clinic where you don't have access to these commercially cross-matching kits anyways, this is going to be your only option for quick cross-matching. It takes about an hour, maybe less if you get pretty used to the process of doing it, but here is the step-by-step process for performing a manual cross-match. Step 1, collect your blood. You're going to need anticoagulated blood from your recipient. You're going to want to put that into an EDTA red blood cell tube, spin it down at the directions of the manufacturer of your centrifuge for separating red blood cells and plasma. Once it's done spinning, you're going to pipette off the supernatant, which is the plasma, into a fresh, no additive tube, and you can discard the red blood cells. If you're also doing a minor cross-match here, you might want to save those red blood cells, but we're just talking about a major for right now. Step 2, collect an EDTA blood tube from your donor, centrifuge it, and this time discard the supernatant plasma to be left with the red blood cell pellet. Step 3, you're going to refill your donor red blood cell pellet tube with sterile saline back to the top of the tube. You're going to throw it back in your centrifuge and you're going to centrifuge it again. Once it's done, again, decant off the supernatant and discard it. Step 4 is repeat step 3 for a total of 3 times. This process is known as the washing of the red blood cells. So you're removing the plasma and the leftover plasma particles from the red blood cells to hopefully just be left with these nice, fresh washed red blood cells. Step 5. You are going to, after the last centrifugation of your washed red blood cells, pipette 0.2 mils of the red blood cell pellet into 4.8 mils of sterile saline to have a 4% red blood cell solution from your donor. Step 6, create your control tube, label it control, add 2 drops of sterile saline with 1 drop of your 4% donor red blood cell solution. Step 7, create your cross-match tube, label it cross-match or label it major, or label it something that you'll know what it is, and add 2 drops of recipient plasma with 1 drop of donor 4% red blood cell solution. Step 8, this is the easy step. Set your tubes down at room temperature and incubate them for 15 minutes. Step 9, come back to your centrifuge one last time and centrifuge your tubes that have been incubating at room temperature for 1 minute. Step 10, take your tubes out, look at your control tube and look at your cross-match tube and evaluate for any hemolysis. There should not be any hemolysis in your control tube because it's your control tube. If there is, we've done something wrong and start over. But evaluate for hemolysis in your major cross-match tube. If hemolysis is present, do not give the transfusion. If hemolysis is not present, continue on to step 11, which is going to be to check for agglutination. If you don't know what agglutination is, I am going to have a video on what agglutination is and how to interpret it, but in short, agglutination are red blood cells sticking together in your tube. And You can see severe macroscopic agglutination in the tube, but you should always put it on a slide and make sure that you confirm it there so you don't have any false positives or false negatives. So take a couple of drops of the Crossmatch solution, invert your tube, take a couple drops of it, put it on a slide, and slosh it around and look to see if you can macroscopically see these red blood cells sticking together. If you can, do not give your transfusion. If you cannot, slide on over to your microscope, throw that bad boy under there, and evaluate for microscopic agglutination. Be sure you know the difference between agglutination and rouleau for this step. Agglutination looks like red blood cell clusters. If there's agglutination, do not give your transfusion. Start over and try again. Do not pass go, do not collect $200. Which means you have another hour of doing a cross match with either a different packed red blood cell or a different donor. But if no hemolysis, no macroscopic agglutination, you can proceed with your transfusion. And that brings us to next week's video. Next week's video is going to be about blood products and how to administer a transfusion. So stay tuned, check back later. If you made it to the end of this video, as always, please like, subscribe, and I will see you next time. Oh, you're so cute. Hug. You're typing. Go type. Oh, oh. Look how cute you are. Oh,